Good afternoon. It gives me great pleasure to welcome you all here this afternoon. And I'm just going to share some slides. So thank you for joining us for the RCSI Charter Meeting 2022, and specifically to our Faculty of Nursing and Midwifery Charter Workshop. My name is Mary Boyd and I am the Dean of the Faculty of Nursing and Midwifery at RCSI, and I will be chairing this session today. We have a very exciting afternoon, and I'm planning that we will take all the questions and answers at the end. So any questions and answers, any questions can be uploaded into the chat box. I'd just like to take a brief moment to introduce a little bit about the Faculty of Nursing and Midwifery. The RCSI Faculty of Nursing and Midwifery was founded in 1974 under the leadership of Miss Mary Frances Crowley. It has a very long, proud tradition of education programmes for nurses and midwives in Ireland. The Dean's Medal was designed by Miss Mary Frances Crowley. The Dean's Medal is mounted on a black background with 8 stars symbolising the essential qualities of leadership. Here you can see the details of current personnel within the faculty. I am supported in my role by the Vice Dean, Mary Godfrey, and Professor Thomas Kearns is the Executive Director of the faculty. Professor Thomas will address us later during one of the presentations. In the Faculty of Nursing, we're passionate about supporting nurses and midwives at all career stages to fulfil their potential through structural education and training courses in the areas of continual professional development. Ongoing professional education and training is fundamental for high quality, safe, person-centred care, informed by and informed leading CPD research. We seek to support the ongoing development of nurses and midwives and other healthcare professionals throughout their working lives. We work with professionals across all scopes of practice, from the bedside to the boardroom. Like all departments within RCSI, we ascribe to the values of respect, scholarships, collaboration, and innovation. Although we are meeting online today, I know some of the events are in person, and slowly we are moving towards a more normal format for all of our events. Through the wonder of technology, we are delighted to be joined today by Miss Margrieta Langins of the World Health Organization from her base in Copenhagen, by Miss Rachel Kenna, Chief Nursing Officer at the Irish Department of Health, and colleagues from the faculty here in Dublin. As we get underway, I'd like to request you to type any questions that you may have for our speakers, which I've said that we will take at the end in the question box on your screen, and we will come to them at the end during our questions and answers session. And now I'd like to start introducing our first speaker, Ms. Margrieta Langins, Chief Nursing Officer from the World Health Organization Europe's office, who will present on the topic of European Nursing and Midwifery Priorities 2022. Over to you, Margrieta.
Good afternoon, Dean Boyd and honorary guests and participants of this wonderful opportunity. I really just want to say how personally how much I've benefited from Irish excellence and expertise here at the WHO, but also personally. And I really just want to thank you for the generosity of your progressive thinking, of your support to me and to the organization, and also your professionalism in healthcare. So really, this is an honor, and I'm very, very delighted to be here with you today. I'm just going to share my slides, and they should be visible. So, as you mentioned, Dean Boyd, I am the Nursing and Midwifery Policy Advisor at the Regional Office for Europe. And this was a position that I assumed this time last year, with the election of the Regional Director of the Regional Office for Europe. And I benefited from the renewed momentum that had taken place across the world to strengthen nursing and midwifery. And it was this momentum through the International Year of the Nurse and Midwife, the WHA resolution, the Global Strategic Directions in the State of the World's Nursing Report, that the regional director made the promise to appoint someone with the mandate to shape and shift the region's priorities in nursing and midwifery. But I have a huge challenge ahead because our regional office covers 53 member states. So we work with our headquarters in Geneva to really implement these policies across 17 time zones, 4 official languages, and a region which most recently obviously was hit by COVID, just like the rest of the world, but we're also now facing the Ukrainian invasion and crisis. And this country and Russia and countries to the east are also included in our mandate of responsibility. Our vision really remains the same, or our work remains the same as it was when we were founded in 1948, when the WHO was founded to support the highest attainable standard of health for all people. But the world really has changed, as Dr. Tedros said in 2019, when he set the 3 billion targets of moving towards 1 billion more people enjoying better health and well-being, 1 billion more people enjoying being protected from health emergencies, and 1 billion more people benefiting from universal health coverage. In the WHO European region, we support obviously these 3 billion targets, and we have something called the European Programme of Work that outlines these 3 pillars that citizens and people of the region can expect from health authorities. And they align very closely with those 3 billion targets of moving towards universal health coverage, increasingly protecting ourselves against health and security emergencies, and promoting health and well-being. But we also have 4 flagship initiatives in the European Programme of Work. And these are the Mental Health Coalition, so changing attitudes and systems, empowering our health systems and our societies through digital health, so the people and transforming the systems through digital health, renewing and strengthening the European immunization agenda of 2030, so really renewing our commitment to disease prevention. And we have an interesting flagship program on healthier behaviors that looks at incorporating behavioral and cultural insights to how we can foster healthy actions for life. There's another context in which we work in the nursing and midwifery program and at the European office, and that's front and center is the building of a sustainable health workforce. And this is shaped by the global strategy on human resources for health and the resolution in the European region in 2007 towards a sustainable health workforce. Now, there are 2 main messages really about these key documents on health workforce. And one is that we approach our thinking in terms of the health labor market framework. So we are always thinking of these things in connection with each other, the education of the health workers, their employment, their jobs, and the services that they provide. And that these are all demand driven. So we're not just creating supply system, we're not creating a supply of health workers, but we're really designing these health workers to be fit for purpose. And the other message that comes really through clearly is really the importance of multidisciplinary and interdisciplinary teams, that really no single health profession can provide all services, that cooperation is essential, and shared decision making, and that there will be overlapping roles, but that we really need to take care and attention to the processes through which these groups work. But also there is an extra emphasis on nursing and midwifery in all of this, and it really is because nursing and midwifery offers a knowledge and expertise that while the world has been changing, nurses and midwives around the world have been harnessing an approach to care that integrates health and social care, that really looks at the communities and the social contexts in which our people and our patients live. And I think this is really important for us to embrace and seize this moment now to really step on this platform and contribute to these interdisciplinary teams. And of course, there's increasing evidence that the nursing workforce is very effective in primary health care, but also with the commitment to a sustainable and interdisciplinary workforce, there are the priorities of ensuring that we motivate and retain our health workers, right? That by creating these interdisciplinary teams, these can be sources of motivation and retention. And finally, the work on health workforce really emphasizes the gender, the social, and the economic resilience that investments in health workers offers to our economies and our societies. So how do we build the nursing and midwifery capacity in the region? I think many of you are aware of the Global Strategic Directions for Nursing and Midwifery, which were supported by the WHA resolution and passed last year in May. And these global strategic directions for strengthening nursing and midwifery highlight 4 areas that really align with the labor market framework. I think the one thing that is really important here is that we also emphasize leadership. And I was really pleased to hear about the coat of arms of your faculty and having the 8 stars of leadership and hearing the words of bedside to boardroom leadership. And I think there's a lot that the RCSI can offer us in understanding how to strengthen leadership in our region. Now, just a little bit before we talk, I mentioned some of the ways we'd like to implement this. I do want to share some of the findings from the State of the World's Nursing Report and the recent evidence that drives these 4 areas. First, we have 7.3 million nurses in WHO European region. We are, before COVID, seeing that 20% of our nurses in this region were nearing retirement, and we have reason to believe that the COVID pandemic may be forcing people into early retirement. But this is 57% of our health workers in the European region. And so it's really, really important for us to focus on really the planning and forecasting through the labor market lens that I mentioned, but ensuring adequate demand for these workers, and that we're doing it with the WHO by applying the WHO Global Code of Practice on ethical recruitment if it takes place, and to really focus on attracting, recruiting, and retaining these nurses and midwives. Because this workforce, while we had the highest percentage of nurses, or the ratios of nurses to patients in the region, we don't have them where we want them and doing what we want them to do. In terms of education in the European region, this predates the State of the World's Nursing Report, but the RN Forecasts work that was published in the Lancet really did show the linkages between bachelor's education for nurses and how it can reduce preventable hospital deaths. But we still don't really understand how much it can impact what is the evidence that we need to support strengthening the nurses in the primary care sector and the community health sector. And we don't always have in our region nurses and midwives teaching nurses and midwives, or teaching in the areas that we'd like them to be teaching. So a priority area here on education really focuses on aligning the levels of nursing midwifery education to the optimized roles of what we want them to be doing, optimizing the domestic production to meet our demand, and to really design education programs that are competency-based and that are using the most innovative pedagogical models and technologies. And this is something I definitely think we can learn from RCSI. In terms of service delivery, the Pulse survey on continuity of essential health services during the COVID-19 pandemic showed us very clearly that there were several reasons for disruption that threatened the supply or the effective use of our nurses and midwives, and threatened access to patients to care. But we also saw approaches to overcoming these disruptions that utilized nurses and midwives very effectively. So we saw nurses being used more and more in triage, in telemedicine. I don't like the word task shifting, but role delegation or task optimization. And there were many unique opportunities where we saw ministries of health in our region that were perhaps previously hierarchical and not as receptive to support, or not putting their work behind nurses, really shift their lens onto nurses. So here, in the area of service delivery, we're really hoping to strengthen professional regulatory systems and really support the adaptation of workplaces that can support these nurses and midwives to maximally contribute. In terms of leadership, the strategic direction on leadership is really looking to establish and strengthen senior leadership positions for nursing and midwifery, for workforce governance and management and input into health policy. And I have to praise Ireland for its exceptional leadership through Rachel Kenna, and how much our countries can learn from this. But also investing in leadership skills development, because the data shows that 89% of nurses in WHO European region are female, but only 25% of leadership positions are held by women. And we had a quite high reporting for government chief nursing officers, but when we actually probed and asked these chief nurses what they were doing, they're not always performing with the mandate or serving with the mandate, the resources and the channels of communication at the highest level to influence policy. And only 56% of countries in the region report having nursing leadership programs. And this is obviously very concerning, because I think as Ireland understands, GCNMOs, or government chief nursing officers, and nursing leadership programs are really associated with stronger regulatory environments, whether we're talking about working conditions and education regulations. So I'm about to wrap up, but I did want to share that in our WHO European region, we have taken those strategic directions on nursing and midwifery and shaped a roadmap to guide the implementation. And it really outlines what member states can do, what WHO can do, and what our different stakeholders can do. So it's not only is it a guide for regional implementation, but it recognizes region-specific priorities. It's supportive of the national health strategies and the European program of work priorities. And it really enforces a little bit further than the global strategic directions, the importance of monitoring and evaluation, because as we benefited from Leuven University that did a mapping of how we do monitor and evaluate nurses in our region, we have some extra insights on indicators that could be useful. So in terms of the work that we will be doing ahead, and I really look forward to future collaboration with the RCSI faculty. I've already benefited immensely from the support of Thomas Kearns and from Michael Shannon, but we'll be working in these areas in terms of education, jobs, leadership, and service delivery, all towards my 3 priority areas: primary healthcare, long-term care, and mental health. So we'll be looking at accreditation and standards for education and interprofessional, but also nursing education. As Rachel Kenna knows, we've been building a network of chief nursing officers in the region, and with every month we're getting more and more nominations of chief nursing officers. So this month we'll be announcing the nursing and midwifery officer for Northern Macedonia, and we meet every month or every 2 months. We're working towards developing nursing leadership development programs. And in terms of jobs, really tackling the issues around working hours, minimum wage, gender equity, social protection, and as the Ukrainian conflict has shown us, because of the indiscriminate attacks on health workers and health facilities, we have a huge role to play in preventing these attacks. And of course, in service delivery, we're working with continuing professional development strategies with countries and advancing nursing roles. So I was asked to give some discussion questions, and these were some of the things that I could think of that were really just to ask you how you as a faculty really feel that you are preparing a fit for purpose workforce. What are the ingredients of success that has made it possible for your faculty to do this in terms of setting context, but also building relationships, and what are some of the capacity challenges and opportunities, but also how you measure impact, and what are you doing to, or what are you considering to attract the next generation of nurses? So I have my contact details, and also we are on social media sites, and I hope that people will get in touch. And I think I'll stop there, Dean Boyd.
Thank you very much, Maggie, for a really insightful presentation. And I'm sure you'll be excited to hear some of the things that we're doing here in Ireland for the rest of the afternoon. And I won't steal anybody's thunder. I'm delighted now to welcome Ms. Rachel Kenna, our Chief Nursing Officer at the Department of Health, who will speak on the very timely topic of national nursing and midwifery priorities, lessons from a global pandemic. Rachel, the floor is yours.
Thank you very much, Dean Mary Boyd, and good afternoon, everybody. I am delighted to be here to address the faculty today of the RCSI meeting. As Dean Boyd has introduced me, my name is Rachel Kenna. I'm the Chief Nursing Officer here in the Department of Health in Ireland, and I was invited to speak to you today about nursing and midwifery policy priorities and lessons learnt from a global pandemic. I'm delighted to be following Maggie and her wonderful presentation. It's always really enlightening to hear of all the work that's going on. I work very closely with Maggie and her team, and you will see that reflected hopefully in what I'm going to present to you today. I'm just going to share my screen. Okay. I hope that everybody can see that now. So as I said, I've just done the introduction there. So just by way of introduction, a little bit about me. As Chief Nursing Officer, I came into the Department of Health here in Ireland about 4 years ago, having spent 27 years on the front line in various different jobs, working at all levels of nursing. I came in then as a Deputy Chief Nursing Officer to be appointed as Chief Nursing Officer in June 2020, so right at the beginning or certainly in the middle of the pandemic. I'm very proud to hold this role, and I've had a very unique experience in it. And I hope what I will present to you today will give you a little bit more of an understanding of what nursing and midwifery policy from the Chief Nursing Office perspective can and is aiming to do, and create a greater collaboration between ourselves for the future going forward. As Chief Nursing Officer, I work at the level of Assistant Secretary General in the Department of Health, which is a senior management position. So they don't make it easy in terms of nursing and midwifery policy. But this does provide us with a very strategic leadership position for the professions. And I represent both nursing and midwifery at that level. As part of my profile, I also have responsibility for several other units within the Department of Health. So real opportunity from a nursing and midwifery perspective to have our voice within other areas of health policy that can influence and support the delivery of strong nursing and midwifery policy. Those areas include strategic workforce planning for the whole health service. So it gives me a real opportunity to interface, particularly on that integration agenda. Population health screening, National Patient Safety Office, which has a really close connection to nursing and midwifery policy, and Professional Regulations Unit. And obviously, as the largest regulated workforce, again, a really important strategic position for nursing and midwifery. I work very, very closely with the Minister for Health on a daily basis, and with Taoiseach's department as well on the wider health agenda. And as well as that, the network extends right into all of the operational areas in the health service, which is another important strategic connection for us. The office then and the structure of the Nursing and Midwifery Policy Unit, just for by way of information, is somewhat unique in its structure. There is a team of civil servants working alongside a number of Deputy Chief Nursing Officers and Project Officers. This gives it its unique face in the sense that we very regularly turn over that essential nursing and midwifery knowledge in the office, keeping us up to date and on point in terms of our position to influence the development of nursing and midwifery policy. Providing representation of the professions at government level puts the patient at the centre of policy, and that's a really important kind of marker in the sand for us. The broad remit then allows far-reaching impact of the office to be felt right across health policy in Ireland. So nursing and midwifery policy then, why is that important? Well, I am passionate about policy and its potential to impact both the patient care delivery, but most of all our professions. Nurses and midwives are the largest professional group, as I've already said, within the healthcare workforce. We have an essential role across the domains of patient care, leadership, advocacy, education, and research. This means that we have the ability to make a difference, to influence across multiple domains. And policy is so important because it helps us to focus our priorities. It provides predetermined courses of action. The action can influence healthcare for patients now and into the future. It supports consistent processes with patients at the centre, promotes quality service provision, and it really does support the empowerment of nurses and midwives. Again, if we're thinking of the purpose of policy, we're striving to support consistent processes and structures with the patient right at the centre. Processes that promote quality service provision and that empower the professions of nursing and midwifery to lead on safer and better healthcare for patients. So why do we need nursing and midwifery policy? The slide there kind of captures the key messages in terms of why nursing and midwifery policy is essential. Considering these then, healthcare systems are rapidly changing and nurses and midwives have responsibility placed on them as professionals right at the heart of this system. We have the opportunity to move and to lead on the changes the professions, through the professions, with the potential to influence on the formation of healthcare policies that support us to make a difference where it counts, right at the point of the patient. The flexibility of nursing, we are uniquely positioned to inform and drive changes at all levels of the healthcare system. Clinical practice is informed by policies, procedures and guidelines to protect the patient and the professions and to provide safe standards and consistency in what we do. Policy development at the CNO level through my office is based on these same principles to guide us from the bedside and beyond and back around again. So we need to be critical thinkers and use our influence in this arena. Nursing and midwifery education teaches us to be critical thinkers. Relating to policy then, we are reminded of the importance of critical thinking to inform our practice at the bedside and way beyond that. It challenges us to be curious about situations we encounter, to make sense of the problems, and that has become a reality over the last 2 years in particular. As policymakers, we need to be able to analyse information, we need to have up-to-date evidence, and we need to have lots of research on both previous and new information to guide specific solutions from a policy perspective. Assess, plan, implement and evaluate springs to mind. The old nursing process isn't too far from the policy making cycle. We've had a significant success with nursing and midwifery policy in Ireland, and I know that a lot of the faculty will be very familiar, but just by way of reminder, we have nursing and midwifery education teaching us to be reflective practitioners, and you can't really move forward without looking back and acknowledging the success we've had with our policies to date and how far we've come. We have the safe staffing framework. We now have 3 phases of this I suppose, in movement. Phase 1 has commenced national implementation. Phase 2 is about to be published. This is the emergency setting. And phase 3 is in the pilot and testing phase, which is a really important phase of the policy because it is based in long-term residential care for older persons. And I think particularly coming out of COVID, reflecting on that, it is a key area that we can influence in terms of having better and safer staffing in these areas. The safe staffing framework is unique in itself. It moved away from the historical approach to staffing and developed a framework that supports the determination of nursing and midwifery staffing and skill mix across a range of settings, putting the patient need first, and it focuses on patient outcomes in order to deliver it. Something new that came out of COVID largely was the community virtual ward. This is a new, flexible, integrated model of working across the community and hospital settings. It receives admissions from both the community and the hospital setting and looks after patients in their own home. As nursing and midwifery roles are developing, we are integrating more and more care from the acute hospital setting into the community. And this model has the potential to provide the necessary framework to support the delivery of integrated care, maximise the use of technology and improve access and choice for patients in service. And then, of course, we have our advanced nurse practitioners, our advanced nurse practice policy, which is, I suppose, advancing on a monthly basis and really came to the fore during COVID-19, where we saw the benefit of having a critical mass of advanced nurses and midwives able to deliver care and make safe decisions for patients. There's a number of factors that we have to consider moving out of COVID in terms of influencing policy, and many of you will be familiar with all of these. So we have advances in technology, growth in population. We have a lot of natural disasters and crisis, and I think at the forefront of everybody's mind at the moment is the war in Ukraine. We have global relationships. You have the public and their ever I suppose, changing demands and requirements. We have poverty, to name but a few. So all of these factors have to be considered, particularly coming out of COVID. So I suppose from my perspective in the Chief Nursing Office, lessons learned and policy direction are significant after the last 2 years. The COVID-19 pandemic has massively disrupted and exacerbated some of the existing challenges in healthcare systems, and that's not unique to Ireland. It has had and continues to have a significant global impact. Long before the current crisis, many healthcare systems faced a variety of issues. Long-term trends such as aging populations and more prevalent chronic diseases have had increasing demands on care for many years. We are also aware of the existing challenges related in particularly to Ireland from overcrowding and increasing waiting lists, and COVID-19 has compounded these challenges. But COVID-19 has also served as a catalyst and the need for transformation, pushing many healthcare systems to make significant changes far faster than they would have done pre-pandemic. From lessons learned, we want to define our shared goals and enhance decision-making through the nursing and midwifery policy arena. The challenges now will be to build on the momentum from those efforts to deliver better care and fortify resilience for the future. I think the area that has seen the most change is that we witnessed innovative approaches to healthcare emerge in the digital health and technology areas, bringing care closer to patients' homes and providing a direct line for patients to use through technology. Nurses and midwives responded and adapted methods to ensure care delivery through telehealth clinics, video appointments, running virtual consultations in clinics. While the concept of itself is not, in and of itself is not new, as a result of COVID-19, digital engagement is a significantly growing trend. We have learned that through the wider application of digital solutions, we can see clear benefits for patients in healthcare systems, helping patients to monitor and manage chronic conditions, for example, reducing travelling time to and from hospitals, promoting greater self-management for patients, and helping them to feel more empowered and have a greater influence on their own health outcomes. Digital technologies already bring benefits to nursing practice and education. Telehealth programs where nurses provide daily monitoring, coaching, triage of patients, and several chronic diseases have helped to reduce emergency admissions to departments. Mobile devices, in particular smartphones and health applications, are enabling nurses to offer remote advice on pain management to adolescent patients with cancer, for example, and supplement aspects of nursing education provided through innovative solutions for content delivery and remote learning opportunities. This lesson provides us with a fantastic opportunity to expand on what we have in place, supporting nurses and midwives through policy to apply digital solutions more widely, investing in and leading in digital health developments and collaborating with others to develop and deliver digital tools that patients and the public need. The big lesson here from a policy perspective is that policy not only needs to develop at pace to keep up with the advances in the digital health and technology arenas, but we need to support nurses and midwives in this space. The other challenge from a policy perspective is that technology is expensive. There is significant patient benefits that we have seen at an exponential level, and our workforce is decreasing. So all of these considerations are really important. Policy is significant in this area, and research and education is going to be critical to the success in this context. Aligning our resources, you heard Maggie talk about the importance of integration in the context of workforce. The health service responded to the unprecedented challenge of COVID-19 and demonstrated a very high level of staff commitment to maintaining services and providing quality care while protecting patients despite the challenges of the last 2 years. A substantial level of innovation in developing new models of care and service delivery was seen almost overnight, where there was whole system responses to services and services adapted to manage the demands on them and continue with as much business as usual as they could, preserving as much of the normal healthcare delivery to patients as possible, and all the while COVID-19 raged through the world. We have seen radical transformation. Nurses and midwives have devised new ways of delivering care, enhanced and adapted existing ways, and kept staff and patients as safe as possible. Strong partnerships have been formed, uniting people working together for this common cause to meet common goals. This resulted in increased home care, more remote care, and striving to redirect care from acute services into the community. And we have all seen firsthand how adaptable the professions of nursing and midwifery are with that. We are growing the need for resources to match the growth in demand for moving care away from the services and into the community. And the key to that is going to be integration of the workforces. Once a crisis is in motion, turning it into an opportunity often requires new ways of seeing things, thinking and responding. We have great roadmaps in place to help us to guide the reform. And in Ireland, we have Sláinte Care as our significant policy direction, moving away from hospital-centric approaches to care to the community and integrated healthcare, bringing care closer to the home and making every contact count, ensuring the right care at the right time by the right person, all fits very well with our lessons learned from COVID-19. We have also learned that we will require flexible policy that is adaptable to meet public needs, supports the needs of nurses and midwives, and appropriate leadership and governance structures to continue to provide and expand the level of integrated care in the community and primary care that we will need. We know from COVID-19 that nurses and midwives will be central to this and that we will require education and training in acute, primary and community care settings at both undergraduate and postgraduate level, as well as continued expansion of clinical nurse and midwife specialist and advanced practice roles in the community setting. One of the significant lessons of COVID-19 is about the mental health and well-being of our workforce. The efforts of nurses and midwives have helped to prevent the impact and spread of COVID-19. Nurses and midwives experienced real emotions and vulnerabilities and fear, bringing COVID-19 into their own families and their own worlds while trying to continue to do their jobs. Nurses and midwives have had to deal with physical, psychological and ethical challenges associated with the pandemic, as well as all the other lived human experience that the rest of the population had to deal with, such as the social restrictions, the feeling of isolation, loneliness, grief, loss, and that included loss of colleagues, families and friends. The rates of burnout in nursing and midwifery have been identified as being higher when compared to other professions and associated with the high workloads, poor staffing levels, psychological demands, poor leadership and challenging team relationships, all reflected in the State of the World Nursing Report as well, in the context of our reducing workforce from a nursing and midwifery perspective globally. There is a much increased awareness on the impact of these cumulative effects of stress and burnout among healthcare professionals, particularly following COVID-19. This has been a particular challenge during the pandemic, and as we move now into a new era, not necessarily post-COVID, but learning to live alongside it, we need to be more innovative and respond to the needs of nurses and midwives as professionals. There is a need to increase permanent resources to support the health and well-being of our staff. Resources and interventions exist currently to help professions, and these have been greatly increased throughout and since the pandemic, or the eye of the storm of the pandemic. But there are lessons to be learned about implementing strategies that provide much more support for coping with very difficult situations and supports that seek to prevent stress and burnout. And this has to be a key policy priority for us going into the future, a key focus on health and well-being of the professions. Embedding nurses in specialist and advanced practice roles within occupational health departments is one way that we should be thinking, focused on promoting and providing enhanced resources for healthcare workers. And this will be central in helping to protect and promote our health and well-being of our workforces. Speaking of our workforce and capacity for resilience, while everybody's situation is different, it may have seen that it is, I think we have all seen that it is possible to be resilient in a crisis. I think inherently we have the means to deal with the crisis, but strengthening our leadership and governance is a priority. Leadership skills emerged and developed in nurses and midwives significantly throughout the COVID pandemic. And I think probably if you look at where we need to focus for the future, from our perspective, there are 4 key areas: workforce, nursing and midwifery education, leadership and governance, and digital health. This is a fundamental requirement in terms of the future and providing flexible policy. We also need to consider the worldwide focus of the WHO strategic directions, as Maggie had given us a wonderful introduction to. This is a spotlight also on education, jobs, leadership and service delivery. The CNO's office is currently developing its strategy for the next 3 years, and this will be the policy direction will be reflected in the 4 priorities as set out on this slide. I think probably education is the kindling of a flame, not the filling of a vessel. Thank you for listening to me, and I hope that you will have plenty of questions that I will be able to answer in the context of policy.
Thank you very, very much, Rachel, for sharing all these lessons and a lot of food for thought there in relation to policy and reform. I'm going to move on to our third presentation today, which comes from the Faculty of Nursing and Midwifery. We are joined by Professor Thomas Kearns, Executive Director of the faculty, and by Ms. Erika Cullen, who will present on their experience of developing a novel bridging degree programme. I understand that Professor Kearns will address us first, then followed by Ms. Erika Cullen.
Thank you very much, Dean Mary, and I want to thank Maggie and Rachel for wonderful presentations. I hope from some of the presentations you're going to see from internally within the faculty, I hope you will see some endeavours to align our strategic intent to the wider policy strategies that's coming to us from both WHO Europe and indeed from our own CNO office in the Department of Health here in Ireland. I was quite taken, Maggie, by the framework you provided at the start in terms of education, leadership, jobs and service delivery. We're going to now talk about a programme that I hope will show one approach to, from an educational perspective, through a leadership endeavour that will address those four frameworks. The work that my colleague Erika is going to talk about and is leading on is a bridging programme, and it started before COVID-19 essentially, but COVID delayed some of the progress in relation to it. And I'd argue that the programme is central and critical in that it addresses some of the challenges specifically in terms of workforce planning, recruitment and indeed retention. And these are the drivers for the development of this programme. And we're also linking to Rachel's work. The need for the programme has, in my opinion, been strengthened by the many recommendations of the report of the expert review body on nursing and midwifery, which was published by the department last month. And what I hope you will see, colleagues, is that from Erika's presentation and then Paul and Kathy's presentation subsequently, you'll see some of the internal work that we're doing strategically to align the education and research agendas within the Faculty of Nursing and Midwifery, RCSI, with our policies locally, nationally, and indeed regionally. So I'll hand over now to Erika. Thanks, Erika. Thanks, colleagues.
Thanks, Thomas. Thanks, Dean Boyd. So I'm going to introduce the International Educated Nurse Bridging Programme. And it's just a snapshot, a brief overview of this one-year programme that's being developed jointly between the Faculty of Nursing and Midwifery and the School of Nursing and Midwifery at RCSI. So we're just going to have a brief overview of the global and Irish nursing workforce and the challenges, and these have been discussed already. The background of bridging programs, the guiding principles of bridging programs. We'll have just a little look at the teaching and learning, what the clinical placements will look like, and the program learning outcomes. So to look at nurse global challenges, we know worldwide there's an imbalance between the skilled nursing supply and the rising needs in healthcare. By 2030, the ICN had predicted a shortage of nurses by up to 10 million. And there is the COVID effect, and these numbers have been predicted to reach up to 14 million by 2030. Now, looking at home in Ireland, we know that in Ireland, the nursing and midwifery workforces are facing challenges in relation to both recruitment and retention of healthcare staff and nurses amongst those. So these challenges will require definitely new approaches to education, a look at re-examination of how we enter nurses and midwives into the profession, and hopefully the bridging programme will move to help with that as well. So as I mentioned, it's a joint project between the Faculty of Nursing and Midwifery. It's a degree programme over 1 year. It's for internationally educated nurses who basically can't or have been refused licensing with the Irish Nursing and Midwifery Board. And that can be due to many reasons. There could be gaps in theoretical during their initial training or clinical as well. And the bridging is to close those gaps. So the guiding principles of a bridging program is basically that you have an applicant, they apply to the Irish Nursing Board, they are refused initial licensing, and then the Nursing Board will give or send a letter of eligibility for them to come onto the bridging program. The first year will be a pilot study. We're hoping of up to 30 cohorts, and they will follow the EMB's licensing and standards and professional code of practice frameworks. So what is the idea of a bridging program? Why do we use bridging programs? What's the research around bridging programs? We've done an extremely in-depth analysis of 13 bridging programs between Canada and Australia. They are very robust. They're used in countries throughout the world. A key findings from the research is that they do help guide and enhance cultural competence, practical theoretical knowledge gaps, they remediate and increase knowledge and practice, nursing practice. They positively impact communication skills and understanding of the destination country's health service and organizational culture. And what some of the findings from the research, although it's quite limited, is that there is overall better quality in terms of patient care and patient safety outcomes when IENs have undertaken a bridging program. And then reports from IENs themselves. There has been reports that in relation to moving to a destination or host country, they have reduced environmental shock, lower rates of occupational health, and reports of their confidence building actually increasing. So the curriculum is basically in 6 modules. The Faculty of Nursing and Midwifery, they have a management program, they're accredited courses, so they will make up the bulk of the education, and we've developed a reflective clinical practice program or module as well, which is over 1,000 hours of clinical placements, which is rotational. So when we're looking at the teaching and learning, the students will participate in evidence-based nursing and midwifery, patient safety, quality improvement and risk management, reflection on nursing and midwifery values for legal and ethical practice, leadership and management, education for professional practice, and reflective clinical practice. And I had mentioned about clinical practice. So through experiential learning, supported with clinical skills labs, inductions, and theoretical group work, students will participate under direct supervision and in all specialities of the nursing, meeting certainly the specialty EMB or NMBI requirements. So they'll spend between 8 to 10 weeks in medical, the same in surgical, rotate care of the elderly, which is 6 weeks, 2 weeks maternity, peds, psychiatry, ED, and OR. And then community nursing, they will work for 4 weeks in that as well. And then the program learning outcomes very tiered or aligned to the domains of competence from the NMBI, which is professional values and conduct of the nurse, nursing practice and clinical decision-making, knowledge and cognitive skills and abilities, communication, management, leader and professional scholarship. And just really to end this brief introduction on this program, what we are foreseeing is that international educated nurses who take part in this program are on a lifelong learning journey. It's a trajectory. They are licensed nurses in their own countries or the countries that they're currently working in, and that they become a very safe nurse practitioner within Ireland, orientated to Irish nurses, and continue their education within the Irish healthcare sector. Thank you very much.
Thank you very much, Professor Kearns and Erika, for presenting on your work in developing the bridging programme. Erika, could I ask if you could stop sharing the screen at the minute? Thank you very much. The next presentation is on a topic of leading impactful research. And this is going to be delivered this afternoon by Dr. Kathy Fitzgerald, a postdoctoral research fellow at the Faculty of Nursing and Midwifery. So over to you, Kathy.
Thank you, Dr. Boyd. Good afternoon, everyone. My name is Kathy Fitzgerald, and thank you for allowing me the opportunity to present some provisional findings from our study on newly qualified nurses and midwives. So firstly, I'll give a brief overview of the European Centre of Excellence for Research in CPD. So the aim of this centre was to establish a pan-European multidisciplinary network of researchers, clinicians, regulators, and patient representatives to advance the science of CPD through research and foster knowledge exchange that will promote best practice in CPD across Europe. So the centre was established in 2020, so quite recently, and currently has members from the following 22 countries here. So the centre continues to welcome new members across all the healthcare disciplines, as it is an interdisciplinary centre, and members of the centre come from a variety of backgrounds, including academia, regulation, and professional associations. So the primary objectives of this European centre is to foster knowledge exchange and develop a joint research agenda by coordinating our efforts to develop a better understanding of the impact CPD activities have on patient health outcomes and patient safety, to develop a common understanding of what CPD means across Europe and contribute to the development of future standards for CPD, to advance our understanding of the economic impact of CPD to inform the development of effective, sustainable and cost-effective CPD activities that impact patient safety and healthcare outcomes, to act as a platform to facilitate multi-stakeholder engagement and to enable access to a global network of researchers, clinicians, advocacy groups in the field of CPD. So the centre comprises of three main research working groups. The first one is looking at evaluating the impact of CPD. Second is digital pedagogies for CPD, and finally the one looking at the economics of CPD. So as part of the first research working group, we are conducting a study examining the CPD needs of newly qualified nurses and midwives. So the COVID pandemic, as has been mentioned, has put a significant the health service in crisis, and this has had a significant impact on the psychological well-being of healthcare workers. So nurses, like other healthcare workers, were not well prepared for the consequences of the pandemic, with long shifts, limited days off work, new organizations, new teams, and new hospital settings. And it is assumed that due to the pandemic, newly qualified nurses and midwives would have had a very challenging transition. So the transition from student to registered nurse and midwife is described as being very stressful, as well as physically and emotionally demanding time. And research in relation to newly qualified nurses suggests that they often describe their first year of professional practice in terms of feeling overwhelmed and stressed, anxious and insecure, and feeling unable to integrate theory into practice. Also feeling a lack of acceptance and respect and sensitivity from their more senior colleagues. So professional support through the participation of CPD activities during this critical time is essential for both competency and competence of newly qualified nurses and midwives. So orientation programs, and these are known variably across the globe as entry to nurse practice programs, transition programs. In the US, they're commonly referred to as nurse residency programs, also preceptorship and mentorship programs. And these have been recommended across the globe. So research into CPD demonstrates improvement in healthcare professional job satisfaction and retention. And there is evidence that it is important to support newly qualified nurses through appropriately designed CPD programs. So in the US in 2010, the Institute of Medicine recommended that all newly qualified nurses receive postgraduate training, such as a nurse residency program. And in 2020, the US National Council of State Boards of Nursing developed an online based program based on the Institute of Medicine's recommendations, which consisted of 5 programs. And these have been described as very important to ensure a smooth transition from student to competent healthcare worker, and also with the potential to improve retention rates. So evidence also suggests that during the transition period, it's also important to provide various types of formal and informal educational support, including preceptorship and mentorship. So the shortfall of nurses is a global problem, and based on the turnover of nurses who leave a particular ward, organisation, or the profession altogether. So a study from the UK in 2017 found that 22,000 nurses expressed their intention to leave the profession in 2015. And the RN Forecast project indicated that about 20 to 50% of nurses intended to leave their jobs across the sample of 8 European countries from 2019. So in particular, there is evidence that newly qualified nurses are leaving the profession at an alarming rate. Cover in 2014 reports that nearly 20% of newly qualified nurses left the profession in their first year of practice. And the National Council of State Boards of Nursing in the US revealed that 25% of newly qualified nurses continue to resign from their first job during their first year of practice, and this is from 2020. So intention to leave and job satisfaction are key factors related to nursing workforce growth and staff retention. So levels of job satisfaction can translate into intention to leave or stay within an organization. And a study from Malaysia in 2013 found that job satisfaction was a significant predictor of nurses' intention to leave. And so recent research indicates that transition period between graduation and starting a new job can be a very sensitive time, but that the characteristics of transition may have either a positive or a negative impact on job satisfaction and staff retention. So there is limited information, however, about the range and extent of CPD activities that newly qualified nurses and midwives participate in during their first 24 months following graduation. And it's also not well known how newly qualified nurses and midwives' participation in CPD activities are associated with job satisfaction and intention to leave and leave the profession, and also what impact the COVID pandemic has had on newly qualified nurses and midwives' participation in CPD activities. So therefore, we developed a study to address some of these issues. So this is a cross-sectional study of newly qualified nurses and midwives in 4 European countries: Ireland, the UK, Italy, and Croatia. So the aim of this study is to develop a better understanding of the CPD needs of newly qualified nurses and midwives, and to explore factors associated with CPD participation during the transition for newly qualified nurses and midwives, and if there is any association with CPD participation and retention and job satisfaction of newly qualified nurses and midwives. So we'll also investigate the impact of the COVID pandemic on newly qualified nurses and midwives' participation in CPD activities. So the questionnaire used for this study, it's an anonymous questionnaire, and it was developed using 3 validated sources. So the first portion of the questionnaire is questions on CPD, and we used a previously validated questionnaire, the QPDN. So it's a 54-item questionnaire, and it asks questions about motives the nurse to seek CPD, the conditions considered necessary to participate in CPD activities, the importance given to nurses, and the actual CPD activities undertaken. We also included the McClusker and Muley job satisfaction scale, and this is a 5-factor model consisting of 25 items. And so the 5 factors are work, culture and conditions, scheduling and family work balance, collegial relationships, intrinsic rewards and professional opportunities. And we also asked 3 questions on intention to leave their current job, the organization or the profession. So the study, as I said, is across 4 European countries, and the plan is to recruit over 1,400 newly qualified nurses and 784 newly qualified midwives across the 4 European countries. And we are collaborating with the University of Genoa in Italy, the Croatian Nursing Council in Croatia, and the University of Hull in the UK. So newly qualified nurses can be recruited into the study if they are currently registered with their professional body, and if they've worked between 3 and 24 months of experience, and if they're currently employed as a nurse or a midwife. And if they're not currently employed or have less than 3 months or more than 24 months experience, they would not be considered eligible for the study. So to begin with, we conducted a pilot study to assess the feasibility of the study and the validity of the questionnaire. So the questionnaire was completed by 48 newly qualified nurses and midwives across the 4 countries. So you can see here that just over half reported that they participated in a program to support newly qualified nurses and midwives, such as a preceptorship or a mentorship program. Over 70% of the participants reported participating in informal CPD activities, and more participants indicated that they preferred face-to-face compared with online CPD activities. So the main motivation for participating in CPD programs was personal and professional development, and the main conditions considered encouraging CPD participations were material conditions, for example, time off work and refunding of expenses to participate in CPD activities. And the most important CPD activities were clinical practice development, and this was also the most frequently performed. So with regard to job satisfaction, newly qualified nurses and midwives indicated that they were more satisfied with recognition of their work from peers, and that was 75%, and opportunities to work and interact with other disciplines, almost 70%. However, they were less satisfied with weekends off per month, just under 30%, and opportunities to be able to work part-time, which was just less than 30%. So just over, with regard to intention to leave the profession, just over 40% of newly qualified nurses and midwives reported that they have thought about leaving the profession in the last 12 months, with almost 10% thinking of leaving the profession almost every day. So the conclusion of the pilot study. So the pilot study assessed the feasibility of the study and the validity of the questionnaire, and provisional findings indicate the importance of CPD to newly qualified nurses and midwives. And the results have informed the implementation of the study on a larger scale. So we slightly adapted the questionnaire based on the pilot findings and reduced the number of questions, and just slightly adapted some of the questions based on the feedback from the pilot study. So recruitment for the main study commenced in January of this year and is currently ongoing. Approximately 700 newly qualified nurses and midwives have completed the online questionnaire to date. There has been a smaller proportion of midwives that have completed the questionnaire than we would have anticipated, And so we have to work towards this going forward. And as with many studies, recruitment has been a challenge at times, especially in the UK and Ireland. So expected study outcomes. So we plan to create an anonymized database to inform further pan-European wide survey of newly qualified nurses and midwives and their CPD needs. And we hope to use the findings from the study to provide recommendations to regulators, healthcare providers and policymakers about the CPD needs of newly qualified nurses and midwives and factors associated with CPD and job satisfaction and intention to leave for this cohort. I would like to acknowledge the following people, in particular Professor Kearns, Francesca Giuseppe and Withold, who are on the team, and also our colleagues in Italy, the UK and Croatia. Without their support and participation, we wouldn't be able to do this study. And I'd like to thank you all for your attention today. Thank you very much. Thank you. Thank
you very much, Kathy, for presenting the findings of that study. It's certainly very exciting, and I'd be very interested to know how you'll get a few more midwives to engage in the process. Our final speaker today is Mr. Paul Mahan, Programme Coordinator at RCSI Hospital Group, Centre for Nursing and Midwifery Advancement, who will speak on the development and implementation of the centre. Paul, the floor is yours.
Thank you, Dean Mary, and good afternoon, colleagues. I hope you can see those slides. Okay. So as we know, and I suppose as we've heard already today, nurses and midwives comprise over half of the health professional workforce globally. And in fact, nurses and midwives are sometimes the only health profession a person may see, with such interactions accounting for anything up to 90% of all contacts with patients. And as we've heard already today, given this degree of proximity to the public, nurses and midwives are a vital resource for health, delivering safe, effective, high quality and compassionate care in myriad clinical settings and non-clinical settings throughout the world and across the lifespan. But as Maggie and Rachel mentioned earlier, just with any other resource, nurses and midwives must be invested in, used wisely, and they must be enabled to practice to the full extent of their education and training. And certainly continued education and professional development play a key role, as we've heard from Kathy, in building domain-specific and transversal knowledge, skills and attitudes needed to match the scope and complexity of care in the ever-changing contemporary healthcare setting. And we've heard already that the faculty was established in 1974 by its founding dean, Miss Mary Frances Crowley, and it's one of the longest established providers of higher education for nurses and midwives in Ireland. And in pursuance of this mission to educate, nurture, and discover for the benefit of human health, and aligned to our values of respect, scholarship, collaboration, and innovation, in 2019, the faculty began the process of establishing an RCSI Hospital Group Centre for Nursing and Midwifery Advancement. And this is just a brief introduction into how the centre was developed and subsequently implemented. So going back to September 2019, the board of the faculty accepted a proposal by Professor Thomas to scope the development of the centre. A steering group was established, and Professor Mary Carney, former Dean of the Faculty of Nursing and Midwifery and coordinator of the RCSI Hospital Group ANMP Forum, was appointed as a project lead to undertake this work. And this took place between November 2019 and January 2020, when Professor Carney held 8 focus groups and 10 interviews with a total of 90 staff across various grades, sites and partner services within our group. And the results of this scope and review indicated that nurses and midwives would be fully supportive of this initiative, and they would both promote it and utilise it. So then at the steering group meeting in November 2019, it was agreed by members that the centre would coordinate and collaborate across the group and share work across 5 areas of clinical practice, practice development, research, education and management. But I suppose, as with many activities across the health service, the outbreak of the COVID pandemic delayed the appointment of the central lead, and that was eventually filled in January 2021. But based on the results of the scope and review, Professor Carney had proposed 4 core competencies of the centre. Those to be a focus on engagement, retention, recognition and reward, excuse me, and continued development of nurses and midwives at all levels. And while these are presented as 4 separate competencies, of course, they interlink with success in one translating to a success in another. But within those 4 core competencies were 44 individual areas for potential action. So a survey was developed to assess what areas senior nurses and midwife managers across the group felt to be of the highest importance and priority. And the first thing we done after that survey was we looked at the internal consistency, or how reliable each core competency was, and it basically it demonstrated that the items that were included within each core competency were reliable. So based on the results of the survey, there were some areas of highest priority and importance were identified, and you can see them there on your screen. These included supporting recruitment and retention, continuing the ANMP forum, scoping the development of CNS forums, scoping the development of new graduate forums, etc. And interestingly, while recruitment and retention was seen as the most important and of the highest priority, it wasn't significantly correlated to any one particular individual item within the scale, which I suppose perhaps points to the fact that recruitment and retention being an end point of everything else we can do to support and develop our staff. So just some of the key actions to date in terms of supporting professional growth and development. One of the key actions has been the implementation of our RCSI hospital group Nursing Now challenge, and we had the first day of our second cohort yesterday. And it was interesting, Rachel had said earlier about the nursing process not being dissimilar to the policy process, and really the fundamental aim of our Nursing Now Leadership Challenge is to build that metacognitive insight and a justifiable confidence in one's competence in our early career nurse and midwife leader, and to let them know that they can lead, they do lead, and that they have the ability to use those transversal skills that they're developing in novel situations. Another key action was the establishment of the RCSI Hospital Group DAISY Awards. Now, the DAISY Awards recognise extraordinary compassion and care. And basically what happens is nominations are received from relatives, patients and colleagues who detail why they feel the nurse or the midwife should be recognised. And to date, as you can see, we've awarded over 250 nominee pins, over 30 awardee pins. We've heard some stories of extraordinary compassion, especially over the course of the pandemic, and these cover the wealth and breadth of nursing activities and are testament to the centrality of the nurse and midwife in the care of the people we serve. Obviously, there quite a lot of the work of the centre transverses the 4 key competency areas. As Kathy mentioned earlier, I'm delighted to be helping out with the Centre for Research Excellence, which ties into some of our competencies, and helping our colleagues in the RCSI Hospital Group with their nursing and midwifery strategy that is building collaboration and community, working with other partners such as Dublin Simon Community, Romanian and Maltese colleagues, also again to build that engagement, collaboration and community across boundaries. And I think I'm over time perhaps, Dean, apologies, and also publishing in terms of creating or contributing to dialogue about policy. And that's a whistle-stop journey of the Centre for Nursing and Midwifery Advancement so far. It's been exciting, it's been busy, and I look forward to the future as we further develop the centre for the advancement of the hospital group, the practitioners within it, and obviously the patients that we serve. And thank you, Dean Mary.
Thank you very much, Paul, for your very exciting presentation. That concludes our presentations for today, and I hope that you found them all very interesting and insightful, especially as I did. We will now have some brief questions and answer session, and to get the ball rolling, I'm going to start with Rachel. I'm just wondering, Rachel, could you elaborate perhaps a little more on phase 1 safe nurse and staffing and skill mix, just to give us a little bit more to quench our curiosity, please.
Sure, I'd be delighted to. This is our longest and best established phase of the safe staffing framework. So the whole ethos behind this was that safe nurse staffing levels are determined through evidence and research based on patient need. So the framework provides a really good structure to support that, in the sense that it looks at the patient and is based on the principle that no two patients are the same. It looks at the staffing and the education levels of staffing on each ward or each care delivery method are an important consideration of the skill mix and the workforce. It looks at the environment that nurses and midwives work in to deliver care, and focuses on leadership and support and supervision. And then it bases itself on, or proves itself through patient outcomes, and measures the success of the staffing levels and the care requirements through patient outcomes. So it's a very exciting researched evidence-based methodology. The formula that we use for phase 1, because it's based in the acute adult setting in hospitals in Ireland, is we use nursing hours per patient day. And through our research, we have seen significant patient, staff and organisational benefits. So from a patient perspective, Mary, we have seen benefits such as reduced length of stay when we get the staffing and skill mix requirements exactly as it is. I probably should have said that our recommendation from phase 1 is that you have an 80-20 nursing to healthcare assistant ratio for the delivery of care in the acute environment. It has given us, as I said, outcomes such as reduced length and stay, a reduction in care left undone, and safer, better outcomes. From a staff perspective, we did see a reduction, interestingly, to some of the information from Kathy we heard today, a reduction in the intention to leave, and an increase in things like break times for staff on shift. And from an organisational point of view, obviously there was economic benefits that really kind of sung to the tune of getting it right from a patient perspective and having the money focused where it is. So a very exciting, I suppose, approach to safer staffing, but also, I suppose, takes into some of the wider concepts of looking after our workforce and the right care, the right patient, the right time, etc.
Thank you very much, Rachel, for that. I now have a question for Erika. What is the value and the benefit of starting an internationally educated nursing bridging programme for the Irish health sector, Erika?
Thank you for that question, Dean Mary. So I think one of the main values is that if we have our own bridging programme, it becomes Irish focused, and that in terms of cultural orientation and also orientation to Ireland and Ireland's health service. In relation to the bridging programme, it would be the first bachelor's bridging programme that we've actually found globally. And also when we benchmarked against 13 other bridging programmes, the clinical hours are above 1,000 hours when we compare to some of the programmes in Canada. That would be about 450 to 200 hours and less in Australia. So to sum it up, the benefit and value is it's a nurse-led program, a nurse-designed program. It's focused on Ireland, and it's focused on certainly developing cultural and orientating overseas nurses to the Irish healthcare system. Thank you.
Thanks very much, Erika. And Thomas, I see that your hand is up. You want to get in.
Thanks, Mary, and thanks, Erika. I couldn't have put it any better in terms of a framework than what Maggie has articulated as a conceptual framework for what we're trying to do. So we're trying to contribute to a workforce challenge that is experienced locally in Ireland, but regionally in Europe and of course globally. And what we're trying to do is, through the leadership of the faculty, construct and co-create an educational program that will give some of our colleagues both a degree and a registration in this country. And that will do two things. One, it will provide jobs for people who need it. And two, I was going to say three, but two, it will support service delivery in this country. And as we all know, as a multidisciplinary health professional university, mobility among health professionals is nothing new. It was there 42, 43 years ago when I started my career, and it will be there in 50 and 60 years' time. So it is key from our perspective that from that global framework and that European framework, this program is pulling together, through our leadership within this organization, the education to support jobs and create service delivery. And thanks, Erika. Appreciate your work there.
And another question for Thomas and Erika. Are bridging programs for internationally educated nurses, are they offered in different countries? And I suppose how successful have these been in gathering applicants onto the programs?
Do you want me to answer it, Thomas, or are you happy?
Go ahead. Yeah,
okay.
Go ahead, Erika.
So what we know from or benchmarking and from a deep analysis, so if we take the Australian Nursing College in New South Wales, per year there are 2,500 applicants and placements in their university, and that's one of many bridging programs in the country. We also looked at intakes, and they range between polytechnics, private colleges and universities throughout Canada and Australia, and they range between two intakes a year to up to 6 intakes a year. So we know they're extraordinarily popular. We know that these bridging programs have been, some of them are around for over 17 years. So they're very robust courses, and as I said, very, very popular with applicants.
Thank you very much again, Professor Thomas and Erika. And I have a question for Kathy. Kathy, do you think that the NQNM would like to participate in preceptorship and mentorship programs?
Yes, so just looking at the provisional results from the pilot, so about 90% of the newly qualified nurses and midwives indicated that they would like to participate in a formal program, such as a preceptorship or a mentorship program. And from the provisional results, about 50% are already participating in some kind of formal program. But there's but these results are preliminary as they're from the pilot study. So going forward, we'll have the larger study. But there definitely appears to be an appetite among newly qualified nurses and midwives to participate in these type of formal programs. However, across Europe, there's considerable variability, with some countries having well-established preceptorship and mentorship programs and other countries having no formal programs at all. But there definitely seems to be an appetite among the newly qualified nurses and midwives to participate in some kind of formal program.
Thank you very much, Kathy. And I have a question for Paul. Can you tell us a little bit more about the Nursing Now challenge and how perhaps a person could apply for that?
Thanks, Dean. Mary, well, in terms of the applications, we advertised the programme through the RCSI Hospital Group Chief Nursing Office, and that's sent out to the various sites across the group, and people are nominated for it. In the challenge in itself, it's a 5-day challenge over a 6-month program. At the moment, we're continuing to deliver most of it virtually, and we kind of split up the days into, I suppose, 3 different activities. So we use our Moodle-based platform to upload some pre-study day resources, so the participants can have an idea of what's going to come up and they can explore the concepts in their own time. Then they come in for the live virtual session where we have international and national colleagues speaking to all different concepts. We kind of team the days into 5 days. So we'll have a QI day, a leadership day, a communications day, a caring for yourself while caring for others day. And then we have post-study day activities as well to further enhance the learning from practice. And this year, yesterday we had a great session where some of the directors of nursing midwifery across the group had pitched some challenges and teams then self-selected. So we're getting people, I suppose, collaborating across the group. We had some wonderful pitches. We had a health and well-being for our workforce, by our workforce. That was one of the pitches. Pitches in regards to metrics, PDPs. So people were able to choose one that suited them best, although some of the feedback from the participants was saying it was hard to actually choose just the one, which was great to see. So they'll work on their challenges over the next 6 months. They'll be fully supported by us here in the faculty. And then they're going to present then in September as groups, and really looking forward to seeing what they produce.
Thank you very much, Paul, for that.
Thank you.
And I have a question or a comment really for Maggie, that the faculty through Professor Michael Shannon and Professor Thomas Kearns are delighted to be supporting the mental health agenda for WHO Europe. So that's a really exciting time ahead. And I suppose one of the things that had come back to me is you posed some questions earlier. What are the RCSI key considerations for the next generations of nurses? And I'd just like to maybe get some of your thoughts on that.
Well, it's extremely important. And I think the conversations that you're having about bridging programs, when we're talking about the next generation, we're not just talking about the people in schools now, but we're talking about potentially people who might want to reprofile or change or are working in different areas of nursing and may want to increase their skills in a certain area. So, I mean, it's vitally important. But as Rachel said, the priorities of digitization could be really important in that area. That's some of the conversations that we're talking about, not just the different types of programs, but also the tools that we use that might be more relevant or might be something that some of our younger generations engage with more and want to apply to health and to nursing. It's a blank slate. It is the year of the youth this year for TEDROS. So we will be hearing a lot of conversations about professional groups. Or young professionals. I will say that engaging nursing students is something that I'd like to see more of. I'm quite surprised that in our region, we don't have a strong, midwifery student group, or we do have a European student group, but there are real challenges to getting them engaged on the global agendas because they are students. So I really encourage universities and faculties to support that, because I think that can attract new students into your faculty to have an international profile or an opportunity to engage with us. So there are various opportunities, I think, in the way you shape your programs, the tools that you use, and the international agenda that you engage with.
Thank you very much, Maggie. And one last question for Rachel. What is the aim of the Department of Health policy that is based on long-term residential care for older persons?
Thank you very much, Mary. I'm delighted to get the opportunity to talk about this a little bit. The overall aim of the policy for older persons care is to provide safe and appropriate care for older people who are living in residential care settings. And I think we've had a particular lens on that throughout COVID, but it's a significant number of our older people live in residential care settings. So the overall aim is to provide appropriate, as I said, residential care to older people in these settings going forward. And part of that is having appropriate nursing care, but also integrating other care needs for older people living in this setting. Our older population, as we know, are living much longer, they're much healthier, and they're living with complex disease. So we need to change the way that we care for people in their older years. And this is an exciting opportunity for nurses to lead out on this in this care area.
Thank you very much, Rachel. I'm very conscious that we need to stay to time, and we've run over a small little bit. And of course, it's Friday evening, so people have places to go. I think that's all the time that we have for questions now. And I'd like to thank you all for engaging with the questions and answer session. It's wonderful to have an opportunity to discuss these very interesting topics. Once again, I'd like to express my sincere thanks to all of our speakers today, Miss Maggie Langins, Miss Rachel Kenna, Professor Thomas Kearns, Miss Erika Cullen, Dr. Kathy Fitzgerald, and Mr. Paul Mahan. And I want to give apologies for Professor Shannon, who had planned to chair the session today, but unfortunately was unable to join us. And I know he would have loved to have been here. We truly appreciate your time and energy, which I know all poured into delivering such wonderful presentations to us here today. I would also like to thank the RCSI conference and event team and their IT support team, who do tremendous work for the annual RCSI charter meetings and have made this online presentation go so smoothly here today. Finally, my thanks go out to all of you who took the time out of your busy day to join us today. I hope you found the workshop interesting and worthwhile, and we hopefully look forward to welcome you onto the campus next year for a fully in-person charter meeting presentation. Have a wonderful evening, lovely weekend, and thank you all.